morning. So for the one or two of you who are in other parts of the country, well done. That's you have an advantage. As ever with the start of these meetings, it's always sad to say goodbye, and it's always a pleasure to welcome people. I would like to record my grateful thanks to Rosie and to David, Rosie Mason and David Wilkes, who have resigned from the board. But I really would like to record my thanks to them for the work they've put in through the last year. It's been the most difficult year in which to play any role in a new organisation. So please can we put that on record? And it's a pleasure today to welcome Anne Alderton, who is in the interim fulfilling Richard Jones's very large shoes. And welcome, Anne. We're really pleased to have you on board for the time being. And can I welcome Chris? I know I welcomed him last time, but a warm welcome to Chris Lawrence, officially in his first board meeting and having just conducted his first audit meeting. So very warm welcome, Chris. And a welcome to Paul Molyneux, who will not be a new face to you, but Paul, I think this is your first official meeting, isn't it? So warm welcome. We will try not to make it too difficult a first meeting. So thank you very much for that. Do I have any declarations of interest other than the normally recorded ones? I'll take that as no. Questions from the public. I've had two questions. A question on fetal monitoring from Liz, which we will record in full, and which I've asked Karen to cover in her presentation on maternity. Liz, is that okay with you?
It is. Can I just add to that the Governor's congratulations on the start of a long journey in the improvement for maternity. It was very pleasing to see a positive report, which always makes a smile on our faces. And I'm sorry, but I did have to ask a question that will be probably, that needed to be asked anyway, and that can come up in the report. But congratulations from all the governors.
Thank you very much for that, Liz. And they are a team that work immensely hard, and I'm sure the board would want to add those congratulations, very much so. And I can see Paul nodding vigorously. The other question from Joe is around the national headlines on the increase in pressure on A&E and the fact that we have limitations to our building at the moment, as you can see by the amount of works going on. And I've asked Helen to pick that up in her presentation, her operational report. So thank you for those very much. I have no other questions from the public. Reviewing the agenda, I haven't been asked to alter any timings, so unless somebody flags to me now that you need to, I will take it that the timings will be as listed. If then we could move to the minutes of the previous meeting, and I'm sure you've had the opportunity to review those. I will take these page by page and try and keep an eye open for your hands. So page 1 and 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Well done, George. Completely clean record. Thank you. If then we could move to the matters arising sheet, please. And if we could take these one by one. We have the first one, which is on community metrics, and that's due to report in July. Does anybody wish to add anything to those? It's pleasing to see that we will see something on that next month.
My plan, Sheila, is to add an update into the integration report for next month. There's been a lot of work going on with therapists and nurses, and there's a further workshop planned. So,
thank you, Helen. That would be helpful. This is not an easy nut to crack. I mean, if it was, we'd have we'd have resolved this issue of community metrics long ago.
So I think the point I would raise is this is a request for some very specific clinical effectiveness metrics. We have an awful lot of contractual metrics around the community contract, and we're trying to get to something that has more clinical value.
That would be good. Okay, then, if we can go on to the IQPR, I'm just going to query, at the moment, the recruitment continues. There's no sort of target date here. Well, no one looking forward, because the target date is the 4th, which was April. Should we have a revised date on it?
We should. I probably need to go back, and unless Craig knows more, I probably need to speak to Joe Rayner. I know we've conducted one set of recruitment that was unsuccessful, which is why we're still not in a place to move it forward. I'll check progress and make sure that by next time we've got an appropriate target for that.
Thank you, Helen. That would be helpful. Okay, if we could move to 1933, which is a midwifery one, and that's on to that we will cover today, I believe. So that's fine. And the SPC charts issue at 1943, that's due to come next month. I'm looking for.
Yeah, so that's going to Insight Committee a week on Monday, and then we'll come back to the next board.
That's good. Thank you. Thank you. Okay, I'm looking at the bottom 4, which are all green and which all have appropriate dates. Any questions or queries or additional comments on those? The only one which appears to be outstanding on its date is the last one, 1957. No comments. Okay. And if we could turn over the page, we've got 2 items which are for today, and the others are all green. I will pick them up if you have a question, a query, or a comment. No. And on the final page, my only query would be on 1976. It says to be confirmed. Can somebody just clarify that?
Natalie was on leave, so I need to date with her.
That's fine. So very straightforward. Thank you. Thank you. Any other questions or comments, or anything you think we omitted to capture for the action points? No, thank you. In which case, can we move to the patient story, please?
Hello, yes. You'll have to give me some time with this one. So we've got a recording that Cassia is reading out a patient story from one of our patients with learning disabilities. And then Helen is going to assist me by playing a YouTube video, short YouTube video, which explains reasonable adjustments. So I will play the recording of the patient story now, and then hopefully it will all go well. Please do let me know if you can't hear it.
Jerry's story. My name is Gerald Sheen, but I like to be called Jerry. I am 64 years old, and I was born on New Year's Eve, 1956. When I was 2, I had whooping cough. In 1960, I was in a car crash. My grandparents, my mother, and my baby brother all died. I spent a long time in hospital. I lived with my auntie, then returned to my dad when he remarried. Both my sisters live in the USA. I left school at 16 and had several jobs. When I was 19, I started working in a hotel as a night cleaner. I worked my way from a cleaner to the duty manager. I am very proud of this. I met lots of famous people. My dad passed in 1996. And in 2010, I had 3 heart attacks. One was a really big one, and my heart stopped. I had to give up work. I really like to help people and have raised thousands of pounds for different charities to help sick children and adults. I have a learning disability, left kidney failure, prostate cancer, epilepsy, impaired vision, hard of hearing, and I also have a catheter. I walk with a stick and a four-wheel walker and wear hearing aids. I have been to hospital 120 times over the years. I think it is very important that staff read my hospital passport, as this would help them to understand, as learning disabilities has a stigma to it. I don't like it when people giggle at me or talk behind my back. I do not have metal cutlery, as I am not safe with it, so staff must give me plastic cutlery. My passport helps me to let staff know these things are important to me. Staff do look after me well, and I like it when they close the curtain to talk to me. I am entitled to some privacy. I know lots of staff, as I have been here a lot, and some of them visit me to see how I am. This helps me when I am in hospital. I need these reasonable adjustments to help me when I am in hospital. I am friendly and I like to talk to people, so hospital can be lonely when staff are busy. Thank you, Jerry.
Thank you. And I'm now going to pass over to Helen, hopefully seamlessly, to play the YouTube video about reasonable adjustments. Let me try that again. Apologies. Can you hear that?
Still no.
No?
No, Helen, we've got no sound still.
Oh. You've clicked the toggle. I did. Okay. I did. I even practiced this.
Technology.
Oh.
Have one more go, Helen.
I'm sorry. Apologies for this. My it's not loaded. The problem is I haven't got YouTube will not load on my computer, which is why I'm unable to play it. Can you hear that?
Yeah.
Yes. Great.
It's hard when I have to ask what words mean.
It's hard for me when people judge me and make assumptions.
It's really hard to explain how I feel.
And it makes it hard for me when people don't get time to see me.
It's hard when people are busy and they don't have time to explain things to me.
It's hard when people talk about me as if I'm not there and they don't involve me.
So please make sure that I am involved in everything that has to do with me. Please take me your time when I need it.
Please get to know who I am and what I like and dislike. Please make things better for me.
Hi, my name is Beth and I'm here to talk to you about reasonable adjustments. People with a learning disability and autism, like me, are dying from things that are preventable, and we all have an opportunity to change this. Through applying reasonable adjustments, we can help people with autism and people with a learning disability receive accessible health and care services as early as possible and live longer and healthy lives. It is important to know that reasonable adjustments are a legal requirement to make sure healthcare services are accessible to all disabled people. We all have our own needs.
I need my carer to come with me to all my appointments because sometimes the doctors tell me things I can't understand.
I want to see a doctor who understands me.
If I see a new doctor, I'll need them to know all about my medical history and what my needs are.
I like quiet places.
I don't like a lot of jargon, so I like the doctor to explain things slowly. If I'm kept waiting, I would like to know what's going on.
Reasonable adjustments can make a big difference absolutely anywhere.
I like to do things and I don't feel scared. It is friendly.
Take the time to find out what kind of reasonable adjustments someone might need, so you can give them the right kind of care.
Bright lights tend to give me a headache when I look at them. If they were to be turned down in the room when being seen by a doctor, that would really help. That would be a really, really good, reasonable adjustment.
It could be giving someone extra time.
I need more time with the doctor so I can explain how I feel.
I need to sometimes explain things and I'm very slow at explaining. Double appointments are good.
It could be explaining things simply, providing information in easy read or in a particular way.
Easy read pamphlets, clearer words.
Some apartments are so confusing trying to find. I wish they'd make it a bit easier in bigger letters and bigger pictures to tell you where to go.
If I got a blood test or anything, I need to know the results clearly so I can understand them.
It could be about giving people appointments at the start or the end of the day when things are less busy.
I like it in the room where it's really quiet, where you don't get stressed out. I like it when it's quiet. I feel calm.
It could be all sorts of things.
Double appointments.
Ramps are a good idea.
I think interpreters are great.
Quiet places.
No jargon.
Handrails good to hold on to.
Appointment reminders are very good.
Find out what each person needs. Check the summary care record. Read their hospital passport. Or, if in doubt, ask the person or their carer. We can work together to get better at listening, speaking up and learning from each other. Often, the smallest adjustments can make the biggest difference to our health and well-being. You can change all our lives.
Thank you. I think that says it all, really, and it's really important for us to acknowledge and manage our patients, all our patients, especially those with learning disabilities, We have recruited a learning disability nurse, Ema, who is working incredibly hard across the organisation and has already made significant differences to us and supporting our staff in how we look after our patients. And we have also hosted a quality assurance visit with the CCG colleagues around how we manage our patients with learning disabilities. And once I've got that formal feedback, I'm very happy to share it with the organisation. With the board, sorry, and the organisation, but there were some really positive highlights within that. Really just to say we are committed to ensure our patients get the right care. We have had incidents where some of our patients with learning disabilities have not had the care that we would have liked them to have had, and so we are co-producing and working with all of those. So I'd like to thank Cassia for bringing that story to the board for us, and the really pertinent video. Happy to take questions.
Thank you, Sue, and you're absolutely right. That was incredibly provoking, and we'll look forward to seeing the result of the work when it comes through. I mean, I think what was going through probably everybody's mind was how are we doing with this? And I think you've started to answer it, and you'll give us a fuller answer as that work comes back. But it did strike me too that actually real patient-centred care means you have that care for every patient, but you adjust it where necessary. Can I bring Chris in and then please?
Sheila, thank you very much indeed. I mean, just with my mental health background hat on, just say how delighted I am to see this and to hear about this, and particularly to learn that you've recruited an LD nurse. I mean, we did a lot of work with East and North Herts and West Herts, particularly around training nursing staff, going onto the wards and just helping them understand how you do make the reasonable adjustments. And because it can be very intimidating, I think, sometimes for nursing staff when they come up against quite challenging people, and people who are challenging not because they are intrinsically difficult, but because they are finding it difficult to sort of communicate. Do we get additional support, I suppose, the next question, from NSFT and the mental health liaison team, particularly when you get people with LD coming into A&E?
So we have Natalie, who is our head of mental health, who is a mental health nurse by background, and she works very closely with our colleagues at NSFT. We don't have any, so I've come from East and North Herts, where we work very collaboratively with HPFT and the learning disability teams within there. We are working to build those relationships. So in answer to your question, Chris, it's work in progress. But certainly Natalie from a mental health perspective, and Ema and Tony from safeguarding all work very collaboratively together, and we are building those frameworks and relationships.
Great, thank you very much indeed.
Thank you. Steve?
Thank you, Sheila. I think it's great to see and hear the story and the focus that we're now giving. And I wanted to say a big thank you to Sue, who's done quite a lot to just review what we are doing to provide better services for those with both learning difficulties. It's really important. It's quite close to home for me. My mum was a special needs teacher, and this was something that was very much part of the home discussion. I should also say we've had a discussion at the ICS board about prioritising our patients with learning disabilities on our elective waiting list, and Paul has been in contact with Ed Garrett, and we're looking to set up a specific task and finish group to look at how we might provide better services to learning disabilities. So it's an aspect of focusing both on inequalities and I think that's a really great step forward. I also think we should hear some of that feedback in terms of taking it into the future system, future hospital design, and I understand that we are both focusing on that, but this to me is a timely reminder to make sure that we build that into the design of the infrastructure for the future. So as well as the great work that Sue's alluded to that is going through the voice group and the specific focus groups and so forth, there's an opportunity to get a better infrastructure that is more shall we say, focused on those with specific both learning difficulties and disabilities. So let's take that opportunity, because the current infrastructure is not, shall we say, well suited for, shall we say, those with specific disabilities.
Thank you, Stephen. That's good for a forward to the future. Alan and then Jeremy.
Thank you. Very powerful video. As this applies probably to all our staff, not just the nursing and clinical environment, is there an option to include that very powerful video in our induction for all staff?
Yeah, we can certainly explore that, Alan, and make sure that it is available to all staff.
Thank you. A good suggestion, Alan. And Jeremy.
Yeah, I just wanted to offer up two reflections that might for us as a board in terms of our learning, really. And one is that for me, this is a reminder that all of our work in equality, diversity, and inclusion isn't about treating everybody equally, because everybody has different needs. But the equality is about making sure that everybody gets the best outcomes, and people have different needs in order to get there. And actually, as a general principle for all our staff and our patients and our population, we have to become acceptable with the fact that everybody has different needs, and we do have to treat people as individuals rather than applying a blanket approach as an organisation. And the second reflection I had really related back to what we talked about last month in the presentation we received about a review of our values as an organisation. And for me, this, just reflecting on our values and reflecting on the messages we heard in the video and in the story, this is a reminder to me that actually setting values for the organisation it's not a soft and fluffy thing to do. It's hard and challenging work, because it's in situations like this and the experiences of patients like this where those values come to life and they're really tested. And I just wanted to acknowledge that and just draw attention to the meaningfulness and the power of properly setting and living values for an organisation.
Thank you, Jeremy, and that's a really thoughtful contribution. It is how you live your values, and living them is not always easy. Are there any more comments or questions? In which case, Sue, thank you so much for bringing that forward. And Helen, thank you for showing us the video. The video, I think, was very, very powerful. Sue, do you have any timescale for when you're coming back to us with the work you're doing on the audit?
So the visit, we're waiting for the formal review, and we've got a meeting in the diary to have that feedback and to discuss it with our colleagues at the CCG.
So reasonably soon.
Yes. As soon as I've got it, I'll table it for feedback.
That's good. Thank you very much indeed for that, Sue. If we could then move on, please. Chief Exec's report. We've had your report, Steve, but I'm sure there's some highlights that you would like to pull out.
Thank you, Sheila. So we were looking to exit lockdown. It's been delayed by a month. There are concerns about the Delta variant, which is a lot more transmissible. There's a lot of press around the breaking of the link between rising case rates and hospitalisations and death rates, but there is still a link there. That the concern is that will drive increased activity. It's something we're very vigilant on. You will see from the performance and operational reports that we are continuing to be even busier. We've seen a 14% month-on-month increase in ED attendances, and the PEDS activity is up about 21% compared to a couple of years ago around a similar time. So we are both prioritising space to meet that. The clinical decision unit has been used to facilitate us meeting that surge in paediatric demand, but we continue to be extremely busy, especially in the context of wards being closed and fail-safe and bearing extension work being completed. So yeah, hugely busy, hugely disruptive for staff and patients, and staff and patients are being tremendously flexible around that. We are opening this week a new space in the emergency department, which will facilitate hopefully quicker, more effective both senior review and treatment of patients, and that'll help with flow and help with some of that additional demand. The intensive care team has moved back to its home, and the estates team has done a great job, not only with the ED space, but also with ITU. The new decamp facility is on track for mid-July, and that will further help relieve a degree of pressure on staff. But teams are working magnificently to process the activity and the patients and meet their needs. And we can't underestimate how challenging that is on top of an already challenging start of the year. Big focus on recovery. You'll see that the long wait is slightly reduced, but we now have theatre capacity out. And again, staff are working evenings and weekends and moving activity into day cases, the day case unit, to try and meet the backlog. You'll see from my report, and Jeremy's mentioned the conversation that we've had around our trust values. We welcome further feedback on those. They're very much aligned to the changing culture that we want to see, and it's great to see the policies that are coming forward around our disciplinary policy, which has been overhauled in response to the feedback and the challenges that we've had around our culture. So very much in alignment there throughout the work that is being done on our culture and our values, and hopefully next month we'll receive the trust strategy. In terms of the new hospital, we are launching a new phase of engagement, and we'd welcome feedback from the public on that, and we're holding a series of events over the next few months. We anticipate that the construction of the new hospital will start around 2025 and hopefully completed by 2027, but we will be looking, if possible, wherever possible, and if funding is available, to bring that forward. Last couple of things. So we welcome next month Clement Maweo. He is going to be the Director of Integrated Community Health and Social Care. It's a joint appointment with the County Council that will further underscore our focus on bringing both community teams and social care together, and I'm sure we'll give Clement a big welcome. A final things to just say, CQC report on maternity services was published this week, and thank you for your kind words, Liz. The teams have been doing a huge amount of work, as we know, which have been reported through to the board. It's very much a journey of improvement. There's still a distance to go, but it's great to see that the Section 29, the warning notice, has been complied with, and the new leadership is making great strides, but still needs to embed many changes. But big thank you to the leadership teams in maternity. Finally, yesterday, Paul and I got the feedback from an MHRA inspection of our blood transfusion service. The board will recall that we've had some documented challenges with the blood transfusion service, with some previously major and critical deficiencies highlighted that we've been working through. It's great to get the verbal feedback yesterday that there were no now either critical or major deficiencies, and substantial progress was acknowledged. There's some tightening of record keeping and the overview of incidents and dissemination from incidents that we got fed back, but that was good, useful feedback. We await the formal written confirmation of the outcome of that report, but it was hugely positive. And Mohammed, the blood transfusion manager, needs to be singled out because he's now leaving at the end of the month to go on to a promotion, but he's done a huge amount of work with the leadership teams in the laboratory to prepare for the lab. So a big thank you to Mohammed, but also a big thank you to the wider team for all that he had done to prepare. And I think it just vindicates the confidence that the board has placed in the pathology team in terms of bringing the services back in-house, because there's a renewed both vigour, excitement and focus, and that was, I think, also commented by the inspector. I don't know whether either Paul or Sue want to add anything in terms of what I've just said there around those last two inspections, but just thank you, because we continue to make strides on our improvement journey. Still lots to do, but great progress, and the teams deserve a big thank you. Paul.
Thank you, Steve. Sue, Paul or Louisa, do any of you want to make any comment, particularly on the last item?
As all, I don't have anything to add, apart from my own personal thanks to Mohammed and the entire team. I visited them before, they were clearly nervous and apprehensive, but the amount of work, the sheer volume of work required to get the standard operating procedures up to speed, and the minute detail that they've gone into in order to get us to this position is mind-boggling. And yeah, they are incredibly chuffed as a team, and as a board we'll obviously want to send our thanks to them for all that hard work.
Thank you, Paul. Louisa, did you want to add anything? Because you've been very close to the pathology team, I know. You've given them great oversight.
I'm thrilled to bits, really, Sheila. This is the first positive step on a journey that they're sort of looking forward to now, because they can see the outcomes and the improvements to patient care. So I think that's really, it gives you that ready Brett glow for those who are old enough to remember that. It's really good.
Thank you, Louisa. I think, between them, you've said it all. So I think we should record our thanks as a board, but to Mohammed, but to the team, because what does strike me, having, seen this journey over a period, the positivity, the enthusiasm that there is now coming from that department. Things are possible when you feel good about things. And I think this is a good example of that kind of positive drive and spirit. And we see that in other departments where there's a real determination to move on, to be better. So thank you all. Paul, you still got your hand up. Did you want to add something?
There was just one other thing. It's a two-way process, and it is just worth feeding back to the board that the pathology team are enormously grateful and recognise the huge investment in time and energy that's been made into the pathology service over the last few months. So as I was going round, there was a constant theme. We've got this new bit of equipment, this is here, we now have this. And there's a clear recognition that the board really had acknowledged what needed to be done and put the necessary resources in place. So it is a two-way thing, of course, and I just wanted to feed that back to the board.
Thank you, Paul, and that's wonderful. And my thanks to my colleagues on the board who've been the people who made it happen. Okay, thank you. If there are any other questions on Steve's report, Richard.
Thank you, Sheila. I just wanted to pick up on the paediatrics issue, which you mentioned, Steve. I know Helen's going to raise it in her report, and that she may want to pick this up rather than you answering. But the question is about the paediatric capacity at the moment, and it's quite clear that at a time when paediatrics is normally quite quiet, it's going to get very busy and likely to get a lot busier. You've talked about the ED preparation for that. Do we have inpatient capacity? Do we have staffing capacity? Are we prepared for a tsunami of paediatric infectious diseases at a time when we would normally not expect it?
I'm happy to pick that up.
Would you like to pick that up in your report, Helen? Because I thought that was part of it. And if any of you were listening to Radio 4 this morning, there was a big section on it on Radio 4. Okay, thank you for the question, Richard. You happy Helen picks it up in her report, which
Absolutely.
we are now moving to, Helen, seamlessly.
Thank you, Sheila. So let me start with the general and the COVID activity. I think Steve has said, and the data plays out. Activity through the front door, both in terms of attendances and admissions, is back to not just pre-pandemic levels, but above pre-pandemic levels. The emergency department is incredibly challenged, but is also coping very, very well. So they are very grateful for the addition of the new isolation area that we brought online a couple of months ago. There's no doubt that that has helped. And earlier this week on Wednesday, in fact, the second phase of additional capacity opened, and I was delighted to go and stand in what used to be medical records, which is probably one of the least refurbished, invested in parts of the building, being really back office. I'm not sure it had even had a new coat of paint since the building went up. And if you go in there now, which I hope you'll get the opportunity to do soon, it's just beautiful. It is a another really good job from our estates teams, from the contractors, and it's lovely. And that will definitely help, but there is no doubt there is a huge amount of pressure. And we are putting more pressure into that team just because of the bed capacity constraints which we have got. So we are at the moment at the worst point in that programme, because we've got another couple of weeks until we get G10 on board to give us a little bit more capacity. So we're at the real pinch point at the moment. The teams are really feeling it, but they are managing it with incredible both resilience and good grace. It is not good to leave patients bedded in the emergency department, which is an inevitability. Sometimes we come in the morning and there are some delays. However, that previous additional area is where we are currently, because we haven't got COVID and we don't need to use it for lots of routine isolation. We are at least able to hold those patients in what is effectively a single room with a sliding door in a quieter environment with a dedicated staff base, rather than being in the midst of the real hustle and bustle of an emergency department. Is it good? No, it's not, but it's a lot better than it might have been. The question that was raised by Joe around, and I was on leave actually, but I did see the incident that I think is referred to in the local press, and the patient went to Addenbrooke's. That is absolutely normal practice, and the patient will have gone to Addenbrooke's because that is the best place for their clinical care. I can absolutely assure you this happens a lot. If the patient had needed to be stabilised in Bury first, they would have absolutely been brought to us. They would have come into a resus, received urgent medical care and attention, and had a clinical transfer to Addenbrooke's for their ongoing care. But they were obviously sent to the right place initially as part of the normal process. And I can absolutely assure you, we have not sent anybody in a critical condition anywhere else because of our capacity constraints. Hopefully that answers the question. I don't know whether there's a couple of hands up. Do you want me to stop and take those?
I think we will, because it may relate to something you've already covered. So Alan, yours has been up for a while. I'll take you first.
Just a quick one on while we're on ED, Helen. I'm conscious over the last couple of years we've piloted new measurement systems for ED. It went a bit quiet during COVID. Now we're at over 3.5 hours journey time. Are there any new targets or guidelines that we need to be watching as a board that may constrain us or change what we do?
So the new metrics, Alan, have been consulted on, and we are expecting some sort of announcement soon, although I've been expecting that for some time, of a date for formal implementation of a range of new measures. We are now getting strong indication of what they might look like, and we are preparing ourselves for that. The first of them will be the time to initial assessment, and the new rapid, you might recall, members of the board might recall, pre-COVID, we piloted what we described as super rat. Rat not referring to rats themselves, but rapid assessment and triage. We piloted that. It worked very, very well. And the last area that opened in ED this week is designated as a specific area for that. Will be manned by a small team, but a senior doctor who was able to receive patients straight from the ambulance crews and undertake a rapid assessment, triage, and stream them through to the appropriate part of the department. So we are very well placed for that. We will continue to report both admitted and non-admitted average journey time. I have seen no indication yet of any change to what the standard metric might be, and we are still continuing to monitor ourselves against the 200 minutes. We aren't quite there on the 200 minutes at the moment, but that is absolutely a reflection of that pressure that I've described and our RAC issues and the lack of bed capacity. I'm really, really confident that if we didn't have wards closed to RAC, we'd still be absolutely, even with these volumes, we would be on track there. There is a new metric called ready to ward, which isn't something we've particularly piloted, and the teams are pulling together a working group now to look at the impact and the implications in anticipation of that standard coming in at some point last year. I'll give the board a full report when we've what I'm describing now is kind of a bit of hearsay and a bit of verbal and a bit of anticipating what's coming, as opposed to having anything formal to report.
Thank you.
Thank you, Helen, for that comprehensive reply. Louisa.
Helen, this may be a question for Helen Davis, but just thinking about managing our demand as we move through the summer and into the autumn, and it's sort of linked really with Richard's comment around the paediatric surge, but also around our increased attendance in ED. Are we sure, or can we seek assurance that we have got consistent messages across the whole of the Alliance and the system in terms of accessing the most appropriate medical provision, and not perhaps using or attending ED unnecessarily? So the sort of point I'm coming from is I anecdotally hear, oh, well, I can't get a GP's appointment, so I'm going to go to ED. And I just think in terms of us trying to effectively, consistently drip that message, it would be, I'm sort of seeking assurance that we've got that strategic. Okay.
So that's interesting. So I was part of a weekly meeting the other day that actually does have ICS comms people on board as well, who Helen and her team will link into. It is quite interesting. There is now quite clear evidence that the usual impact of messages asking people to stay away from ED is an increase in ED attendances. It is thought that what happens is we start to flag, and it brings the fact that ED even exists into people's minds, and more people attend, so it has a reverse effect. The other point I would say, yes, there is an awful lot of anecdote around this is all because we can't get to see a GP. There is also an awful lot of evidence that tells you your GPs are also incredibly busy. 111 is incredibly busy. This is heat in the system in its entirety. This is not just that the GPs are, I know there is a perception that GPs are sitting on their hands or playing golf. They're not. GPs are busy, 111 is busy, community services are busy. And we are busy as well. There is an increase in walk-in attendances, and there is potentially an area where people can't get to see their GP, but that's because the demand for GPs is also at 120% of pre-pandemic levels. So it is a real challenge, and we are working as a system, and actually it's not just us, it's a national challenge, so there's quite a lot of national work going on. I know partners in ESNEFT are planning a very detailed piece of work using some students to do detailed interviews with their patients. We will obviously be keyed into that and pick up the key learning and the messages. They'll be similar. I don't think we need to do the same exercise as they are already planning to do it, but we will be keyed into that, and we are looking to make sure that as well as telling people to stay away, we simplify how they access other services and the confidence they have in the advice and the treatment they'll get from those other services.
Thank you, Helen, and I'm very well aware it's been a source of discussion both in the chairs group and at the board at ICS level, because you're right, it's right across the system and nationally. Helen, did you want to add anything on the sort of communications messages?
So James has just shared a link to an article in the East Anglian Daily Times the other day about this. So we are flagging messages. I think it like Helen says, it is just heat within the system. I think that's a really great way to describe it. And we do try and ensure that people know where to go. And all we can do is flag those messages. So I think it's about continuing to do that, and also trying to understand what exactly the pressures are in the system and what's causing it.
Okay, thank you, Helen. Okay, Helen, did you want to continue, please?
Okay, so picking up on the question around the paediatric activity, this is a point in time where the paediatric activity and the RAC failsafe are colliding, unfortunately. We do have to, as part of the programme, deal with paediatrics. And when we open G10, let's get those details right. When we open G10 in mid-July, it has been agreed that we will move paediatrics into that environment. It is not an ideal, temporarily, it's not ideal, but there is no ideal environment. We have no other area in the trust that has as many side rooms as we have on the paediatric ward. So that unfortunately means that just at this point in time, there's a real pressure point building there. As part of the ITU work, we have created a specific paediatric side room in critical care instead of it being a bay at the end. That will absolutely help. And also, as part of that work, the critical care team and the paediatric teams have done a lot of closer working together, which will help. The teams are very aware of what is coming and are planning within the limitations of our estate. We don't provide paediatric intensive care, but we are planning to stretch our resources as far as we can and linking with the paediatric network around that. I've had conversations this week with colleagues at Addenbrooke's around what mutual aid support they may be able to give us during our decant. Typically, they are also planning some additional works for their paediatric area to prepare for the winter and this expected surge. And would you not know it, those two things are happening at the same time. However, those are just the challenges we have to deal with, and we will deal with it together. You know, we have a good, positive relationship with that network. I can't sit here and give you great assurance, Richard. I can tell you we're doing what we can around it, and we're working in the system to get it right. And we'll get the paediatric fail-safe complete programme done in one go, so that we don't have to move them again, and then get them back into their home environment. Is that okay? Sorry, I can't be more positive on that one. And I think the end-bearing piece of the paper is what it is, but just to confirm, the ITU did move back into their main unit at the beginning of this week. They're very pleased with that environment, and that piece of work has gone very, very well. And we were commended, actually. I thanked colleagues on a regional call earlier this week for their support and mutual aid, and we were commended for the professional way in which we'd managed during this period of time, which I've passed on to the critical care team, which was good. You've then got the usual levels of activity data. Just to remind you, with that caveat, the final column is the latest week's data, where it always looks like a dip, but it's a recording and a data catch-up issue. So the best thing to look at is the 4-week picture across all modalities, which is showing a very positive position against the plans we have. And the final thing I just wanted to say, I have included here the IQPR purely because the Insight Committee did not meet. This paper will go to the Insight Committee on the 5th of July, and potentially you will definitely get a report next month, but that I just felt uncomfortable that there was potentially a delay, and I wanted, for transparency, for people to have had the opportunity to look at it. I don't plan to go through it, but I'm happy to take any questions on it if people have got them.
Thank you, Helen. Richard, could I possibly look to you as chair of that committee? Is there anything there that you would wish to comment that you kind of have picked up in your mind might be a priority for the committee to have a close look at? Sorry to jump on you.
No, I think that's fine. I think the two things that I know that we discussed at our previous Insight Committee, the endoscopy and investigation performance, and we'll certainly want to pick that up at Insight. The other thing that Alan actually raised is with me earlier, is the 2-week wait breast symptoms, which looks a bit strange. There may be a simple explanation for that falling off a cliff, but that is something we can either pick up now or we'll pick up at Insight.
I'm happy to we will pick it up in more detail, but just to give people some assurance, and you will recall this is what I say around this. So in line with lots of other trusts, we saw a significant increase, i.e. about a 70% increase in referrals into the breast service a little while ago. That did come off the back, I think, of either a celebrity or a soap character, a breast cancer story, and we often then get heightened awareness. So we have struggled with the demand in line with colleagues at ESNEFT and others across the region. But as I've always said to people, when people do then get to see the breast service, they get a complete one-stop shop. So although we were not meeting the 2-week wait standard, which is what you see reported, we are at over 90% for the 28-day diagnostic standard in breast. So they're actually being seen at about 3 weeks, not 2. The performance is improving and they are doing really, really well against the 75% standard for diagnostics within 28 days.
Thank you, Helen, and I know you'll delve into it in slightly more depth in the Insight Committee, and thank you, Richard, for picking that out. Were there any other questions on the IQPR or Helen's report? Because if not, we've moved into the territory of the 3 Eyes Committee, so I think that it's logical if we move there. So Improvement Committee, we have improvement here. Did the chair or Sue, did you want to comment on that?
Really just to say this continues to be an iterative process, and that at our recent improvement committee, I mean, Louisa chaired it, so I don't know if Louisa wants to tip in, but we received a really comprehensive review around our deteriorating patients, and we are continuing to work with the team, and in fact Rebecca and Lucy are putting together a sort of work schedule to proposal for the improvement committee going forward, and we've got a meeting this afternoon to really tie up how we have our communications between the 3I committees and to make sure that we're assured we've got all of our ducks in a row, our I's dotted and our T's crossed, and we're not losing anything through the cracks. So we'll be able to give, I'm sure we'll be able to give a better update next month, but this will be an ongoing iterative process, so watch this space. But it was a very positive meeting, I think, Louisa.
Thank you. Louisa, did you want to add anything?
I think it was a positive meeting, and it's it was helpful for Sue to sort of make the comment she's made. It is Anne's helping us, all the committee chairs, in terms of how we work together, and we, you know, the overall approach is so that we make this streamlined for the supporting committees, and we make sure that we don't miss anything, that we pick up everything from the previous really effective improvement programme board. But actually it's making sure that we dynamically and appropriately measure those things that are important to the trust, where we need to take some steps forward, but actually that we empower staff who actually deliver the service and can deliver that kind of change and improvement to actually take the lead. So we had a really effective duty of candour presentation by Rebecca Gibson, and that's coming back next month because that's important to the trust. And we're sort of looking at, you know, our sort of plans we go forward in terms of looking at those issues that, you know, are important to us and that are important to other clinicians. So it is an iterative process, but it is about how we work together, how we move forward at speed.
Okay, thank you very much, Louisa, and thank you for stepping into the breach at the last meeting. Can I then just turn to Alan briefly, because clearly involvement was only this week, so we haven't got a report, understandably, from them. But I thought perhaps you or Jeremy might want to make comment ahead of that. And then if I may, Anne, I'll draw you in to talk a little bit about whether your assessment, your working with the 3I committees is. So Alan, if you would like to start, or Jeremy, I don't mind which.
I'll pitch in first, very briefly. Firstly, great to have Anne on board, and also James McFarlane, who I think is going to play a role in terms of quality improvement across the piece here. I'd just like to raise 2 content issues that came up in involvement. Firstly, from our patient experience team, they raised, I think, an important issue about the fact that we don't really have a systematic approach or a toolkit to ensuring we have patient engagement, or indeed stakeholder and other engagement across the piece. We're very good at it at times, not so good at others. And Cassia is looking forward to putting forward some kind of proposal that we build a better systematic approach to this across the organisation. And it may even be broader than patient engagement. It may be indeed a change management kind of process that's a bit more disciplined. So that's the beginning of a journey, I think. The second was that Jeremy advised us that we're going to be able to measure some of our involvement and engagement a bit better going forward, because there's going to be more rapid quarterly national staff surveys, perhaps not as big as the annual one, but by having quarterly feedback from staff, we'll be able to see much more quickly whether initiatives we take, whether it's in improvement or whatever, are actually biting and having an impact. So I think that's a good thing, because it's been frustrating to have a very slow annual cycle. Thank you. Jeremy, did you want to add or emphasise anything?
Yes, thanks, Alan. And you'll have probably spotted it, but there is a bit more detail about the quarterly staff survey in my report for this meeting, which I will cover a bit later.
Thank you. We'll pick it up there.
The only other comment I would make is that we provided the Involvement Committee with an update on the rollout of the Freedom to Speak Up champion role that Amanda and James presented to this meeting. I think it was the end of May. That is now being socialised with staff. It's been published to them, lots of roadshows and discussions happening over the course of the summer, and we have started to get self and other nominations for Freedom to Speak Up champions coming through.
Okay, thank you for that, Jeremy. Anne, I'm going to come to you now, if I may, because I'm conscious we're still at the forming stage with the committees, and you know, these are really important committees for the board. They are assurance committees for the board, and I think we will all welcome when we have slightly more detailed and formal reports coming forward each cycle. Anne.
Yes, I mean, it's the vision for the new committee structure is bold and exciting and different, and that can sometimes be a little bit scary. On the plus side, I think we do have a lot of work to do. And it's not just about the assurance committees themselves, it's about articulating what the board wants from the committees, and the interface with the board assurance framework and the risk appetite that the board has articulated. And those are also pieces of work that are very relevant here. But as to the committees themselves, I think the most important piece of work that needs to be done is the reporting and information flow that ensures that things that need to be escalated do get escalated, and that they're escalated to the right committee to provide assurance to the board. That's probably more important than the terms of reference. But there is more work to be done on the terms of reference, and there's more work to be done to, I suppose, look at the board work programme and how the committee work programmes feed into the work of the board. One thing that I'm really pleased about was that because I mean it is a very different looking committee structure. So I immediately went to the well-led governance standards that are set by NHS EI, and there is a very good correlation between the key lines of inquiry in the well-led governance framework and our committees, and I think if we reflect that explicitly in the terms of reference, that would be a very good place to build on.
Okay, thank you very much indeed, Anne. Are there any questions on the 3 I's at this point? Okay, we look forward to the development stage moving on at pace, and reports next month. So thank you all for that. If there's nothing else on the 3 I's, I'm going to move then to finance and Craig.
Thanks, Sheila. So we're at that strange point in the cycle where we are both discussing the last year and the current year. So significant focus of the finance department over the last month has been on finalising the accounts and the position for last year, which is very nearly at the end of that process, and the figures for last year remain as presented to the board previously. In terms of this financial year, the board will be aware, first 6 months of the year we've been given certainty around our income position. That allows us to project a break-even position for the first 6 months. We're achieving in line with that over the first couple of months of the year. We're expecting to get a degree of additional certainty around the second 6 months of the year. Our expectation at the moment is that we will break even in the second 6 months of the year, but that's heavily dependent on the assumptions that we're making that, as I say, should be borne out in the next few weeks. The only other points that I choose to pick out of the finance report are the CIP. Board signed off a much more limited cost improvement programme than we've had in previous years, for obvious reasons, given everything that you've already heard at this meeting that we are dealing with, and we're broadly on track to deliver the cost improvement programme. In terms of cash, our cash position is much healthier than it has been in previous years. That was true last year because we were receiving income in advance of expenditure deliberately. This year there are significant items of expenditure that have been included in last year's financial position that have yet to materialise as a liability. And again, the biggest one of those is the annual leave accrual. So this is where staff were carrying a lot of annual leave over into this year because of an inability to take it last year. When they do take that leave, we'll incur costs, and that will deplete our cash position. So although our cash position is very healthy at the moment, we would expect that to return to more normal levels over the course of this year. Then the final point is around capital. You will hear capital referred to at a number of points within the board meeting. Capital is severely constrained this year, and that does have consequences on the way the organisation will run. The exception to that for us is around the improvements that we're making around the structure of the West Suffolk Hospital building. That constitutes the majority of our capital programme, and we progress with that. But outside of the structure, capital expenditure is very limited, and that will have consequences for the organisation, and you will hear about that in most board meetings for the rest of this year. Other than that, Sheila, happy to field any questions.
Thank you very much indeed, Craig. It does feel as if that normality is kind of hovering on the horizon, but the new normal is not really defined yet. And given where the government's economic circumstances are, I think it would give any board a pause for worry. But it's good to know that in the short term, you and your team have done extremely well in putting us in as good a place as you can. Any questions for Craig? Okay. I think you've blinded everybody with financial science.
Sheila, this is a first for me. I think in all of the board meetings since I started at West Suffolk, this is the first time there have been no questions on finance, so thank you very much.
Thank you. Craig, do we need board's authority to sign off the accounts?
I'm not sure, Anne, when we were planning to do that. We can cover that now. You're on mute.
I'm on mute.
We could cover it now, or and in terms of where we are, yes, we could.
Well, we've raised it. Shall we do it? Craig, do you want to explain?
Yes. So we had a meeting prior to this board meeting to review the the annual accounts. So the audit committee met. There are still some things that need to be worked through around the annual accounts. It has been a challenging year for the auditors, so they are auditing our accounts remotely and are suffering with staff shortages in the way the rest of the economy is struggling at the moment. So there are still some things to do. We're not where we would normally be. So a set of accounts were presented to the audit committee this morning, but there are still some things to finalise. The accounts need to be submitted by Tuesday of next week. So the recommendation from the audit committee is that the board approve the accounts subject to any changes. And if there are any changes, that the board delegates authority to principally the chair and the chief exec and the finance director to sign off those accounts on behalf of the board on Tuesday. But Chris, as the chair of the audit committee, may want to come in.
Chris, can I bring you in?
Yeah, thanks, and thank you, Clay. You've taken the words out of my mouth. It is deeply, I think, frustrating for everybody that we're at this position where we are not able to finally sign them off today. I just wanted to sort of say that Craig and his team, Liana and others have worked flat out, and the auditors have worked flat out, but COVID has created issues for everybody. I think we're satisfied on the audit committee that the accounts are substantially in their final form. The outstanding issues, we've been through them line by line with the auditors. They are not material. They will not affect the numbers that you've seen. And therefore, I think it's entirely reasonable that we ask for the delegated authority. And I just wanted to recommend that to the board for their approval.
Thank you very much indeed, Chris. And can we extend as a board our thanks to Liana and all your team, Craig, who've been getting those together. I know how much midnight oil gets burnt at the end of this process. It's a really tough time for your department. So please pass those thanks on. Is the board happy to agree to the delegation? Thank you. Okay, thank you. You have that. And you didn't get a question, Craig, but we did give you a slight issue. Okay, we are due for a break. I'm going to suggest we take 10 minutes. We will reconvene at 11, please. We are dead on time on the agenda. So thank you all very much indeed. That might be a first as well, Craig, for the chair. So I suggest, because of the complications of connecting, you merely switch off your camera and your sound, and we will see you back at 11. So thank you all. people side of the business, so to speak. So the report that we've got on the papers, please, at 13.
Yes, thank you very much. So I'm going to start on page 3 of my report, which talks about the HR policy framework work that is ongoing at West Suffolk, and it's best described as a piece of work through the subtitle that I've used in my report, really, which is about improving our people management culture through having more compassionate HR policy frameworks. And we've made our disciplinary policy, which at face value is not necessarily a pleasant word, but it's a particular policy or framework that every employer needs to have to reflect employment law and best practice. And we have completely reviewed our own West Suffolk policy, working in partnership with our course of the last couple of months. This is very much about embedding a change in culture. It's about learning lessons from mistakes that have been made in the past. And it is also learning the lessons from elsewhere in the NHS about how you can tackle issues. But first and foremost, it's about learning from something that goes wrong, seeking to understand what happened and the issues that contributed to it, rather than first and foremost focusing punitively on an individual or team or whoever has been involved in the incident or set of events. And that really is the underpinning ethos of the policy, which is attached as an appendix to this paper. Really, this is a policy that is approved at our Trust Council. So it's a policy that the Trust Management and staff representatives agree, and that has been agreed, and will now be published on our website. But given its importance and its prominence in things that are important to us as a board, I brought it here today for our endorsement as a board. Supplementary to that, in terms of our sort of local focus on this, there's also a national focus on this, and over the course of the last 12-18 months, all trusts have been asked to review their disciplinary frameworks, and we've been asked to publish our new policies in our public board papers and on our website. So it also satisfies that national requirement as well. And the detail in the paper provides a bit more of the steps that are being embedded in the policy to give you assurance around the style of people management that we want to see in the organisation reflect that change in culture that is our aspiration. There are other things that we've embedded already that has been reported to the board around the case tracker, the anonymised case tracker that is provided to the closed session of the board on a regular basis, which focuses on learning. And the board will also recall the process that we went through in the autumn to review cases and the pause that we put in place for all of our live HR cases, and to ensure that we were exhausting all options around informal resolution of issues that were being tackled at that time. So that is presented to the board today for endorsement, and also, of course, any questions or queries you may have. Developing that a bit further, it is one of the many things, this policy change, that will sit within our longer term people plan, which is still under development at West Suffolk. There's an update in my paper around that and how we are proposing to combine the national people plan priorities in the NHS with those that we think are important to us here locally at West Suffolk. This was something that was briefed to the involvement committee earlier this week, but I've included it in the paper today as well, again, given its importance to us as a board. The question at the moment really is, in terms of the stuff on the right-hand side of that table, the draft goals, is there anything we're missing before we then go and develop the detailed plan and take that much further in terms of leads and deliverables and timeframes? So feedback welcome on that as well. We've already touched on the implementation of a quarterly staff survey for the NHS, and there is some narrative detail on that in the paper. And finally, before I pause, a moment to celebrate and record our appreciation for particular colleagues at West Suffolk through our Putting You First scheme. There are 3 awards that we are making today, as highlighted in the paper. Firstly, a group of individuals on Ward F3 who were responsible for facilitating a very complex discharge for a specific patient, which required reasonable adjustments to be made to ensure that individual was fully prepared and supported for that discharge in an incredibly complex set of circumstances. So thank you there to Cheryl, to Kelly and to Emily, who were nominated by Helen, who's the head of nursing for surgery. The third nomination there on page 3 of my report is for Elizabeth Keegan, and it gives, this is really a carer-led nomination. It talks about an email that's come from a parent to thank her for kindness and compassion showed to her son upon discharge, and the approach that she took in terms of the sensitivity shown to that particular patient and family. And finally, you will indulge me by celebrating some individuals on my team who I'm very proud of. So Danielle and Harriet, nominated by Angie and my team, but also praise in this nomination for Diane Last and the education and training team that she's responsible for. This talks about our particular success in our international recruitment program and in our healthcare support worker program. And you've got some feedback that we've received there from Region that underlines the relative success that we're having here at West Suffolk compared perhaps to elsewhere. So Cheryl, Kelly, Emily, Danielle, Harriet and Elizabeth, particular praise and thanks for their contribution to life at West Suffolk in my report. And I'll pause there. Thanks, Sheila.
Thank you very much indeed, Jeremy. And I think we celebrate them all. It's wonderful to have individuals who make a difference, but the power of a team when they all work together to make things happen is quite phenomenal. Are there any questions? There is the policy document. There may be some questions on that. Chris, was yours on the policy document or something else?
It was really on the disciplinary framework, and I just wanted to say how pleased I am to sort of see the comments around just culture and improving people management culture. And I just wanted to sort of say that obviously this isn't an isolated sort of compartment where we're only just dealing with things that go wrong, but it obviously sits within the overall framework of values and culture as expressed through behaviours right across the trust. So really, really pleased to see this.
And I'm pleased to see the direct line to the time that was spent by Steve and other senior leaders in the organisation with the Merseycare team and working through their culture. And I think, we can begin to see threads being drawn together into the way we do things. And policies, let's face it, do encapsulate the way we do things. Any other questions or comments on that particular piece of work or on anything else from Jeremy's report? I know there'll be a more in-depth dip high involvement committee into the work that's going on, and we'll look forward to your report coming back as well as Jeremy's report next month. Alan, you've got your hand up, and Steve.
It was really just reflecting your last point, Sheila. We were thinking about the role of the involvement committee. We're very conscious we're not a decision-making committee or a place to formally endorse things. So our role, we thought, was to just test with Jeremy and the team that this policy change had followed proper engagement sort of processes with staff reps and others, had looked at best practice, had looked at national guidelines and so on. And so rather than create a whole industry, we thought we wanted a sort of tight process there of purely checking and getting assurance that good involvement and engagement had taken place.
Thank you for that, Alan. That's very useful to be clear on. Steve, can I bring you in, please?
Thank you, Sheila. Just to underscore my thanks to Jeremy, Claire and the team for the review and update of the disciplinary policy. As you said, and I think Chris has echoed, major milestone, major focus on evolving the culture with a focus on just and learning. So that's really welcomed. We do need to ensure, though, that the policy is followed and adhered to. So I think we need to build in down the line some way of evaluating how we are both following the policy and contributing to the wider perception that things are changing. Can I just endorse the putting you first citations? They're fantastic and a lot of hard work and sensitive care, and also just pull out the two consultant microbiologist appointments. That's a further investment in both the lab and the team that surrounds that, and I think those are two great appointments that will further help with the resilience of the laboratory team, and those are not easy to recruit to. So that's a major milestone and achievement to get those two great candidates on board.
Thank you, Steve. Thank you, Steve. Alan, your hand's still up. Was that a legacy hand?
Yeah.
Okay, thank you. Can I just make one comment, Jeremy, from your report? And it's a small piece in your report about the library service. I do want to highlight, I mean, they're just amazing. They just keep going, whatever happens. And they're often the unsung bit of the trust, but I think they're so important to us. And they always manage to be cheerful and calm through whatever's going on. So, yeah, I think we should just acknowledge them, because they're the team that often don't get that praise, and it's well deserved.
Absolutely. Two quick comments from listening to Alan and Steve. So as evidence of the partnership working to co-create this new policy, when we launch it to staff and the organisation in July, it will be Claire and Paul with my exec backing that talk about it. We'll include it in a staff briefing, and they will appear together and talk together about it. So that will be a visible sign of the partnership that has been there to develop it and the joint work we're doing. And in relation to Steve's point around making sure that the policy is lived and adopted, I mean, this is very much supported by our investment in the HR business partners, HR professionals that are now embedded in the divisions. They are every week involved in coaching type conversations with line managers and team leaders to help them informally deal with issues. And whilst it is not necessarily my style to put in sort of particular requirements in how HR processes are implemented in organisations, actually we are saying that if any manager wishes to rely on sort of the formal processes in the disciplinary framework, then that must be in consultation with my team. So that is there as a safeguard. It's not there as a big brother thing. It's there to provide a supportive safeguard for everyone, staff, for managers, and that's how we will take it forward and evaluate it.
Thank you, Jeremy. That's very helpful. Paul?
So I just wanted to endorse the benefits of the HR business partners. They are incredibly helpful to have embedded within the divisions. I found them a useful resource even in the 3 weeks that I've been medical director, and they are universally helpful in providing input for those low-level concerns that don't meet any criteria, but just need some really good, sensible, pragmatic HR advice. So I just wanted to make that point.
Thank you, Paul, and that's really great free feedback to have from you, because that's from the experienced user's end, if you see what I mean. So thank you for that. Are there any other questions for Jeremy? Because if not, Paul's in the chair, and I will move to clinical revalidation. And Catherine, welcome to the board. And Paul, did you want to introduce it before you?
If that was possible. So, Chair, just to welcome Catherine in the spirit of greater clinical leadership engagement with the board and exposure of our excellent clinical leaders to the board and vice versa. I thought it was really important to invite Catherine Rowe to this board to present the paper, which after all she has done a significant amount of work on. So, by way of context, Dr. Rowe has had significant leadership experience elsewhere. She came to us, as I remember, a couple of years ago and was already the lead appraiser at a former organisation. And my stepping aside from the lead appraiser role was necessary as I take on the job of responsible officer. And Kath interviewed for this role and delighted to appoint her. And it's also worth pointing out that the board reporting cycle is slightly unfortunate because it fell to her to present a report for the board about 2 weeks into her job. So I'm personally incredibly grateful to her for taking on this challenge at a particularly difficult time, because appraisal has been thrown up in the air and the bits have landed in very different positions over the last year. It was suspended for 6 months and then there was a graded introduction. So to ask her to present an appraisal report for the board at very short notice was a big ask. And I'm personally very grateful to her for the work that she's done. And I will now stop because I'm sure Dr. Rowe would like to speak to the paper and answer any questions, which I'm also happy to help with.
Thank you, Paul, that's quite an introduction for you, Catherine. I mean, but it sounds as if this is familiar territory to you, albeit not at West Suffolk. So I'll hand over to you to introduce your report.
Yes, so I think as Paul's highlighted already, quite a lot's gone on in the appraisal and revalidation process in the last year. I think the first thing really was COVID last year, where from March to October, all appraisals were cancelled for that 6 months period. And then in the 6 months after that, there's been a period where clearly clinicians were in the second phase of the COVID wave and also required to do their appraisals. Also within this time, Paul stepped up, Nick stepped down, I've stepped up. The administration support, Janet Rolfe has retired at short notice, and we're in the process of training a new person, Lorna Watson, into appraisal itself and revalidation. And also one of the problems is learning the software for Allocate, which fortunately I'm familiar with. So actually between us, it's not ideal, but it's fine. So with regards to the board report, lots has been done in the last year. And I suppose the main things to point towards are actually what actually has happened. So we can see from the AO report figures in the chart in the middle that actually over half have definitely had their appraisals either on time or a little bit late. There is a large proportion in the category 3 section on the right hand side of that chart. Now at the moment, me and Lorna are going through those in fine detail because some of those individuals may not be in the right category. So we're purging the system to make sure that we're absolutely correct of the people in category 3 to find out whether sometimes some of them may have been actually approved and missed, but actually been reassigned into the wrong category. But other than that, we're happy that the 1 and the 1As have been filled in and the 2, and if anything, the 2s may be higher. So in the next couple of months, what we're intending to do is purge the data system and work on the appraisal and revalidation process as a whole, and taking the opportunity to have 2 new people who are in the trust and seeing things from a fresh perspective. And actually Paul's been really supportive of that. So I think in some ways it's a really challenging time, but I think we need to embrace it as a great opportunity to move forwards. So in the last year, quite a few new appraisers have been actually started within the trust, and I'm looking forward to actually looking and working with those appraisers moving forward and actually doing some quality assessment of appraisals. With the Academy of Royal Colleges, they've changed their framework as to how the quality outputs are measured, so I will be doing that according to their new framework. But that means that actually the appraisals will be of a good and valuable standard, and actually will be supportive of revalidation decisions, but also the value of appraisal, which actually I think is more important than actually getting numbers in the correct box. We've changed our processes of our revalidation support group, so we've increased the diversity of it. We're also changing it into the working day rather than being in the evening. We're also aiming to reduce the paper that was being used, so that we're actually using the functionality properly of the Allocate software rather than having a folder, which means that actually we can work from home or interchangeably or whatever it's required to do at short notice with data that is actually live and real and not reliant on a folder in an office. And we're looking at actually capturing those short-term doctors, which are at a national level probably the most problematic with regard to appraisal, the doctors that move between trusts at short notice contracts. And actually it's finding those as part of our system as they come into our hospital and making sure that we have is inclusive. And that's where we see our focus in the next year. And that's about it, if you have any questions.
Thank you. I'll open it up for questions. I have to say, it's music to my ears, the quality assessment of appraisals, because so often we count beans rather than actually reflecting on the quality of what we're doing in appraisal terms. So that would be a really good piece of work. Alan.
Hi, Catherine. I'm a big supporter of revalidation. I have a question, though. I understand there's a degree of confidentiality about the process, which is sensible, but can we use the opportunity to get feedback from the doctor community about the quality of leadership and things like that they experience? In other words, rather than just focusing on the appraisal of the doctor, can we use this structured process to listen and learn about their feelings about our own management and even board, if you like, because we've been criticised for having poor engagement with consultants at times. So is there some way, or do you gather that feedback in any way to help all of us?
So I think there's sort of a question mark about the purpose of appraisal. I mean, the purpose of appraisal is about quality assessment and fitness to practice. Undoubtedly, there are themes within the appraisal portfolios, which, as I've started reading through them here in this hospital and in my last hospital, there are themes without a doubt about the culture of the organisation that we can pick up. But we have to remember it is a confidential document. My feeling is that there are other ways of asking this information. I don't know, Paul, if you want to lead in on this as well.
If I could come in, the well-being work that I began a journey towards about 3 years ago was really kick-started because I, as the lead appraiser, had oversight of the appraisal summaries. So the soft intelligence that you get as the lead appraiser around the things that were coming through was instrumental in actually allowing us to start the work, the Better Working Lives group, do the burnout surveys and establish that whole chunk of work around doctor well-being. So at a sort of high level, both Kath and I have oversight of the appraisals and review a proportion of them as part of our quality assessment, and that's great for picking up themes. But I do agree with Kath, it's a confidential discussion, and so it would be tricky and I'm not sure helpful to use the appraisal methodology as a way of picking up that more detailed intelligence, Alan.
Am I not right in thinking, Paul, too, there's something called the medical engagement scale, which we're thinking of bringing in as a tool, which actually would give us another way of actually finding and working on that information.
So that's right, and I think a paper's coming back to board in September that Jeremy and I are looking for around the whole process of medical engagement, and obviously the risk of survey fatigue is considerable. So whether or not we choose to use the medical engagement survey as a tool or use some other intelligence through the patient safety survey, the staff survey, that's something that we're looking at.
Yes, I think this issue of fatigue with surveys is going to be a real issue moving forward. Alan, sorry, you wanted to come back.
I understand the issues, but I'm disappointed because I feel it's a lost opportunity. When I'm appraised, I'm able to give feedback up the line, and I hope people are listening. And I respect the confidentiality issue. I just feel we should use every opportunity to listen and learn. And I hear that you are, Paul, rather than saying, oh, we'll just do it through other processes. You know, we've got this structured process. Why not carefully and confidentially, you know, listen two ways? But I understand what you're saying.
Thank you. Jeremy, you wanted to come in.
Yeah, it was just really to empathise with that. But I've been through my own struggles in terms of understanding the differences between medical appraisal and non-medical appraisal, and there are some real fundamental differences between the purpose and scope of those. So, for instance, a lot of the components of what you would see in a non-medical member of staff's appraisal in terms of their relationship with the organisation, engagement with team or personal objectives, that for a doctor or a consultant doctor, those are the sorts of things you see in job planning rather than in appraisal. So there are definitely more appropriate places for those sorts of things to be discussed and should be than medical appraisal.
Richard, I think you helpfully wanted to come in from a
simply just a selection support group, so I'm involved with the appraisal process, and I just endorse what Catherine, Paul and Jeremy have said. I understand Alan's point, but I do think there's a big difference between the purpose of medical appraisal, and I think we need to focus on that and make sure we don't get distracted from that. But of course, using soft intelligence, as Paul has suggested, is perfectly reasonable, but I think we need to be careful of focusing on what the medical appraisal is about.
Thank you. Any other questions? We have in the recommendation, when noting the contents, are you happy to approve it for submission to the higher level responsible officer? I'm going to take that as yes. And approve the statement of compliance. Do that. Can't see any hands up. Okay. Thank you very much indeed, Catherine, for coming and presenting.
Okay,
and apologies, it was at rather short notice, so to speak, but we shall look forward to seeing you again in the future.
Okay.
Thank you.
Bye.
And thank you. Okay, in which case, can we move on, please, to the quality and safety reports, and maternity being the first one. Sue.
Thank you. As always, Karen is here to present the maternity paper, so I'll introduce Karen. I think, Karen, you missed the thanks from Liz at the beginning of the meeting with regards to the CQC report for maternity. So I don't know if, Liz, you just want to reiterate it so Karen can hear it before she launches into her papers.
Liz, I'm sure I'd like to.
Yes, Karen, I just wanted to say thank you on behalf of governors. We all read in the press a positive, article, and we were pleased to see the positive article as opposed to always having to see something negative. But I'm sad to say, Karen, I do have a question for you, which Sheila's going to bring on. So, but, keep going. It's a long struggle, but you'll get there. Thank you.
Thank you. Karen, I think you've already got the question, haven't you, which is on fetal monitoring.
Yes, so yes, I can answer the question regarding fetal monitoring. So fetal monitoring is one that notoriously has been very difficult because it's what people are expected to do in their own time. That's across nearly every trust I've worked in. It's something that's called a K2 package, and it's e-learning, and it takes about 10 hours to complete. And the reason that people are expected to do it in their own time is because in some areas of work that you do have opportunities in work time to complete it, but it is something that you would be expected to do as a registered midwife in your own time, as do the doctors. And I think we've had a change in how we actually report it, so it's very difficult to explain. So probably up until, I can't remember, really sort of like the middle of the financial year, we said actually we can't keep on reporting it as an annual figure, because what would happen is the whole package would close. I think it was on something like the 11th of June, and everybody had until the 11th of June to complete it. So you could have started it on the 12th of June, the next, for the following year, and then almost have 2 years to complete that programme, which obviously then doesn't mean that you're meeting compliance. So we knew that when we went over to reporting it on a monthly basis, that we would actually have a bit of a hit in our drop of our compliance, because that's not how it's always been done, and that was very historical. Because June was always the cut-off point, we knew that around May time we would have a bit of a dip, because people are still thinking that kind of the mentality, I've got till the 11th of June to get it done. But we also do now have the issue that we are expecting people to do it in their own time. And on top of everything else, what people, I'm not the first one, I'm sure, that's told you about how staff are feeling. People are not doing extras. They are coming to work, they are doing their job, and that is pretty much it. So we do have to look at how we are going to support that. We have applied for Ockenden money, and one of the things that we've applied for is to backfill people to do their fetal monitoring training. We haven't had, unless Craig tells me otherwise, we haven't had that come back as definite of how much we're going to get, if we're going to get anything. But one of the things we definitely did say was to backfill for the fetal monitoring training. Does that answer your question?
Can I just come in there, Sheila? I don't think, if I could just read the question out, just because nobody else heard it, it wasn't read out at the beginning. So no, you're fine, Karen. I just said at the March board meeting, I asked about the low results for mandatory training in maternity, and in particular fetal monitoring, and the reply indicated that there was an 18-month period that this could be done in. And now I see in the papers this month there is once again a very low take-up, and the explanation is that compliance changed in January. And my point was that I just wanted assurance. I wasn't aware that this was to be done in their own time, but I would say, as a person that very many years ago had a baby that had to be monitored regularly, and when I hear of people that go into hospital and they're stressed and they're worried because they don't know whether their baby is right or wrong, this seems to be a very crucial part of the training, discounting that. So that's really why I brought it, Karen, because I know I did raise it before, but I just feel it's one of those crucial things.
Yeah, so absolutely. So it was not 18 months, it was actually, they had nearly 2 years to do the training the way we used to do it. And so in January, that's when we actually went, no, we can't do this. We can't keep on doing it like this because people are not being compliant with the year. But, it is absolutely crucial, like every single part of maternity mandatory training. So just so I can give a bit of comparables to you. So as a registered nurse, pretty much they will have 1, maybe 2 days that is mandatory training. It's midwifery, it's just growing and growing and growing. So most trusts now will offer 5 days mandatory training for midwives. We only have a 22% uplift on our staffing to cover training, annual leave and everything else. It makes it incredibly hard. And then also we've then got to staff the unit. So it doesn't mean that we're not seeing it as as important. We absolutely are. It's very difficult because it is an e-learning. So there is part of it the individual does have to do in their own time. And they do have to, as a registered practitioner, whether you are a doctor or a midwife, you do have to take that responsibility that you will do that. As I said, ever since I've been a midwife, that has always been my responsibility to do my fetal monitoring in my own time. But as everything grows and grows and grows, and now the package is 10 hours, and that is mammoth to ask somebody on top of everything else, especially in the current climate, to do in their own time. We try very hard where we can to get people to do it in work time, but we are short. Let
me hope then, by focusing on it as a governor, we can elevate it up to something of more vital importance. So thank you, Karen.
Thank you. And can I just say, it's not that it's not vital importance, I just want it that we need to be able to support people doing it in work time, and that is the real difficulty that we have at the moment. But
no,
yeah.
I quite admire it, Karen. I'm just trying to put your case forward. Thank you.
Okay, thank you. Karen, I think there's a big issue there which we need to return to, because it is about training and opportunities to train it in dedicated time, and the balance that needs to be struck there, particularly given the pressure staff are currently under. But we'll come back to that. For the moment, can you just go through any highlights of your report?
So the report, sorry, you have got so many attachments, but hopefully you're aware that our Ockenden submission is due by the close of play Wednesday. So there's quite a few reports I just wanted to give you oversight for. And then CNST is due 2 weeks later, so I'm sorry that you've been inundated on reports, but it's just to give you an overview of what's happening. Just so I can let you know, from a CNST point of view, we will be doing a paper per step as such, just to give you an overview, which we will be presenting hopefully to the execs, just so they can prior to us submitting that. Also from the report, you'll see that I've said that we have the draft CQC report. Obviously we've got the full report now, and we've already started working in putting the recommendations, or the musts and shoulds, into our maternity improvement plan. That's already commenced, and I'm sure Sue has already informed you that we've actually rectified a few of those already, so that's good. The NHS staff satisfaction survey, just that we are continuing to do work on that, and what we are now doing is we are doing focus groups for staff, particularly the band 5s and the band 6s, that is being run by a manager outside of maternity, so we can make sure that people feel like they are being able to be really open and honest there about how they're feeling about work. And then the other, just to really talk about, is the maternity dashboard. So again, we have not got the clinical data that I can share. Reason being is e-care, we are doing masses of work, and I'm very optimistic that I've been told that they are hopefully be able to produce something soon. So we are meeting on Monday just to go through the final parts of that before we present to the execs on Tuesday. But a couple of things just to kind of people know, so obviously the fetal monitoring training. Also, I think there was a question regarding the WHO checklists. So the WHO checklists this month and last month have dipped below our 95% compliance, just marginally. And I have to say, for the 5 months prior to April, they were consecutively above 96, well, 96 to 100%. So it is a just dip. It's not that they're not being done. And this is where it's, we scrutinise everything. So it's not that it wasn't done, it's just that not everyone had signed it. So it's often the checking out process where the person it's normally the one person from theatre who has to rush out, and actually they just forget to sign it. So that's where it normally is, but that's why the compliance is like that. The swab count compliance we are very concerned about, and we have been doing quite a lot of communication about it, and it hasn't made a lot of difference to our compliance. So we felt that we had to take a different approach to it, and looking at from a just culture point of view, we decided, okay, we will do spot checks, but actually not spot checks to tell people off, is to actually have the opportunity to ask people why, what's happening, what's the problem here. And we have identified a few issues. One is e-care. So people are getting really confused. We have got the swab counts in all of the rooms. We have got signs up saying remember to do your swab counts, and what is happening is that people are actually doing their swab counts on eCare and not on the piece of paper. So this week we have looked at every single delivery that required a swab count or a suturing, and I can say that we are 100% compliant, but it might not be on paper, or it'll be paper or eCare. And I think going forward, we just need to use one system. So, but the difficulty with that is because you have to have a second checker, and that's the difficulty. And that's why we thought for ease, it was easier if you had the piece of paper and the person be in the room. But obviously, I think we have to move over to eCare. And sorry, that's a really quick overview of my paper, unless anyone else has any questions they want to ask.
Thank you, Karen. That was an amazingly clear view of the overall. Richard, can I bring you in as maternity champion?
Yes, so just say thank you, Karen, for an extremely thorough and an excellent report. There are a couple of things I want to say. The first is what you've just mentioned about the approach to the swab count issue, where you've actually gone and worked out what the problem is rather than pointing fingers. That's just fantastic, just brilliant. But I also wanted to acknowledge the amount of work that's going on in the background. I've been involved in discussions about the Ockenden report, and gone on behind the scenes for Karen's team has just been absolutely enormous in preparing all the information required for that. So thank you, basically.
Oh, thank you. It has been mammoth, I'm not going to lie.
It does feel as if the mountain you're climbing keeps getting a bit taller, doesn't it, Karen, I think?
I'm really honestly, it's not going to stop. It's not going to stop. We know this is Ockenden Part 1. We know Ockenden Part 2 is going to come out, and it's, yeah. That's fine. We can do it, though.
We have every confidence in your ability to do it, Karen, and your team. Sue?
Yeah, I just wanted to reiterate thanks to Karen and the team, because as Karen quite rightly said, we have sort of put a request in for some additional funding through the Ockenden requirements, but it does seem to be that every single day we get further requests for further information, and this isn't just with us and within West Suffolk, it's across the whole country, and it's not going to stop. So we just need to be mindful as a board that we will need to continue to support, and that you know, we need to continue to review our resources and ability to do that, because it is really difficult for our midwives to continue to do what we want them to do, which is provide safe care for our women, but in addition to all the additional requests. And I know that we've been very fortunate as a team to receive the additional posts, and I know Karen's felt very supported by those additional posts. It's like we're consistently asking for more, but I think we just need to recognise the national ask on this, not just the regional or our own ask. But thank you, Karen.
Thank you. And just also, so for you who are aware that May Buckley, our improvement officer, I was speaking to her last week, and she acknowledges that smaller units are almost penalised because they're asked to do exactly the same as any other unit who has got far more support staff, because they will have business project leaders and everything else. And she said, but you're asked to do exactly the same as everyone else is. And, you know, just because we're a small unit doesn't mean that our standards are any less or our safety is any less. And that's what we have to prove. And it was quite nice hearing it from a director of midwifery who oversees 3 really busy trusts in London. It's saying, actually, you've got the tougher job here. So that was really good to acknowledge.
It's always good to know you've got supporters, Karen, and thank you for your report. And please pass our congratulations on. I hope that those of you who haven't have read the CQC report, because actually within the text there's so much encouragement and noting and recognition of the journey you've travelled so far. Yes, we know there's still some way to go, but you know, it's been an amazing journey of progress, and with some pretty difficult constraints. And you know, the issue about training and staff is really one of them, and we do need to acknowledge, you know, midwives are rather special and are quite, I was going to say, rare commodity, but you know, we know that there are national issues about numbers and recruitment, and that additional pressure along with the burden we put on them in so many ways, and not just the day job, is very considerable at a time when everybody is tired. It's been a very, very long 18 months. And I do wish we could sort out these issues of double counting, because they happen in other places where we have two systems, because it always leads to muddle. Paul, you get the last word.
So, notwithstanding all the work that Karen has done, I also want to just acknowledge Kate Croissant and Ravi and all the obstetricians that have been involved with this. The engagement that they have to what that sometimes appears an overwhelming burden of reporting, and yet at the same time focusing on all the really important things that are going on. It's a difficult time and a challenging time, but actually it really feels to me, in the last 3 weeks of my, the first 3 weeks, the time I spent on the maternity unit, it's a really engaged and cohesive group, and it feels like it's in a much better place.
Thank you, Paul. And on that note, I'll say thank you, Karen, and we will move on down the agenda to infection control. Sue, over to you.
Thank you, Sheila. So you will have the report that gives an update on our ongoing COVID situation. We have got no COVID positive patients in the organisation at the moment, and we continue to swab as per our regime. What I did want to bring to your attention today, and it's not written within the report because it is still an evolving picture, but I think it's worth just bringing to the board's attention that we have we are managing at the moment an outbreak of VRE, which is vancomycin resistant enterococcus. This is a naturally occurring, well, it is an occurring organism that is in about 1 to 2% of the population, and it's normally, it wouldn't necessarily cause you any problem. The reason that we have become aware of it is because we've had an increased number of specimens that have tested positive for this organism. Therefore, what we're doing is we are working with our microbiologists, our regional colleagues through our normal incident management team meetings and our infection prevention control team, and our public health consultant to review every single case, plan what we're doing, and manage the situation. This is something that takes some time to A, understand the extent of the issue, and B, then manage it through our mechanisms of infection prevention control. So to assure you, we are absolutely reviewing all of our infection prevention control processes, our enhanced cleaning, and managing it that way. We've informed all of our patients, and we are working through screening where it is necessary. Our areas of concern are ward F6 and we are looking at F3. But that said, we're not just looking at those areas. We have reviewed critical care, and critical care are okay at the moment. But as I say, this is a sort of a commensal, if you like, and it can cause infection if it gets into places like wounds, catheters, or any other kind of nephrostomy tube, drain, or whatever. So to let you know, we've declared it as an outbreak. We're working collaboratively with our teams across the CCG. We've got a CCG assurance visit next week coming in to look at our infection prevention control mechanisms and our cleanliness. And I just want to thank all of the team, because we've had amazing support from our housekeeping, from our microbiologist, from Anne Swift, our public health expert, consultant, and from all of the microbiology teams, and all of the nurses and medics are fully engaged within this. I'm happy to take any questions. I don't want to give too much more detail. I will provide a written update for the next board.
Thank you, Sue. Are there any questions? That was a fairly full explanation. I think it sounds to me as if we just need an update on where we are in the process for the future. And obviously, if there's any major change, an update between board.
Yeah.
So thank you for that. Thank you, Sue. Do you want to go straight on to nurse staffing report?
Yeah, and Dan's here to do that.
Welcome, Dan.
Thank you, Sheila. Good morning, everybody. The nurse staffing report to inform you of some highlights, taking the paper as read. Again, reasonably positive month to report within the month of May. And the highlights I'll pick out is the overall trust fill rates for our nursing and healthcare assistant support workers at a trust level is above 95% across both days and nights, which is again positive, which is evident on page 2. We have a total RN vacancies rate has improved with a small increase of a vacancy rate within our inpatient areas, but that's a very small 0.1% increase, so nothing too worrying. Our substantive total figures have just slightly dipped on this month, following a number of months of improvement, and I will obviously update any further trends as we go into the future. On the subject of vacancy rate and future pipeline, we have discussed at this meeting before around presenting a future pipeline to the board, which we are still working on and is not yet at completion. It's a very complex process to get a pipeline as accurate as you can, taking into account various variables, but also it does rely on a number of different data sets and teams to provide an input into that work stream, so it's not as simple as you would think. So, but hopefully, with the progression we've made this month, we should have something for you next board. We did present for the first time last month around turnover, and it was raised that our nursing assistant turnover was just above our 10% ambition. I can report this month that has gone down to 8%, around 8%, which is positive. Bit early days to say whether that is due to our additional pastoral care resource and support we're giving them when they first join the trust, but it might be a contributing factor, but it's a little bit early, too early to say. I would suggest to celebrate that just yet. And finally, nurse sensitive indicators have improved again in both falls and pressure ulcers this month. And we're seeing a 4-month sustained improvement for pressure ulcers and 3 months for falls, and that is mapped against occupied bed days as well. So incidences are reducing, and also instances when we're looking at capacity as well. I will pause there and take any questions.
Okay, thank you very much indeed, Dan. And I suppose just one general question for me to start. We've heard a lot about how exhausted and tired and people are. Is your sense that there is a danger at this point we could actually lose some of our nursing workforce who, putting it prosaically, decide that working in Sainsbury's is probably less stressful?
I think there's always that danger. I think some of that is not sure how much that's based in fact. We are seeing, obviously, as Karen's alluded to, staff that are exhausted, but we're not seeing staff leaving in droves as yet. I think one of the worrying things that me and Stu have discussed around staff resilience is not necessarily the response to COVID and continue to work in the NHS, but it's that constant uncertainty, and we have identified areas of worry, if you like, and for us that is areas that have been consistently moved around. So the likes of the short stay, the elective care programme, who have coped remarkably well, but they do get a change of plan, a change of direction at short notice, and that's probably more of the worry than recovering from COVID, in my opinion. And some other areas too, similar to the short stay areas, that the move around the organisation does impact on that slightly, but that will settle down, I hope. And we've done additional work with those teams, with the wellbeing services, to make sure that they are able to verbalise those concerns as much as possible. But I can't say there's an emerging theme of an exodus at the moment. It doesn't look like that from a turnover perspective just yet, but obviously we are constantly mindful of that.
Thank you, Dan. And that to me seems to be quite a positive message, and some of the mitigations are in our hands. Okay, I'll open it up for any other questions. I don't see any currently, so can I thank you again for the report this month, and we'll look forward to it next time.
Pleasure. Thank you, Sheila.
Thank you very much indeed. In which case, could we move on to the digital board agenda, and Craig?
Thank you, Sheila. I think this is a sort of function of timing, but this is the report that has to come to the board that details the digital board that was held on the 6th of May. I think there's not much in here that wasn't reported to the last board meeting. So I am happy to take any questions, but I'll also pick up some of the future system stuff in the next report that I'm going to cover.
That would be good, because I think we may get some questions about digital in relation to future systems. So let's wind them together. I think that unless there's any separate questions, which I don't see anybody raising a hand. So Craig, do you want to move on, bringing the digital into that?
Thanks, Sheila. So as reported at the last board, we had the digital fortnight, which basically established the program that we will be working to as we roll through the future system program. That's we're working with Atos, who have been employed by the Department of Health to work with the new hospitals program in its broadest sense. I think it's safe to say that we're potentially developing a blueprint that will be used by the rest of the new hospitals program. So there's a lot of exciting stuff happening around the digital aspects. Steve picked up an awful lot of the future system report in his report, so I don't want to repeat that. But the principal other work we've been doing is around the clinical model and the way that feeds into the schedule of accommodation. So that's the work that has been ongoing and will continue through the next few months in the run-up to the submission of the planning application at the end of the year.
Okay, that's really helpful. I don't see any hands being raised. Okay. In which case, you confounded everybody again, Craig. Thank you.
Thank you very much.
Okay, could we then move on to the governance report? And Anne, if you would like to start, and I'll come in with the councillor governors.
Yes, I'm struggling a bit managing the paper and the screen for Teams. So bear with me a minute. Yeah, here we go. Yes, just to report what's coming up for the next meeting. And the governance activities that are currently ongoing. I suppose the main item for the board to approve is the item that was discussed earlier at the Audit and Risk Committee, which is a certificate of compliance that we are required to self-certify, approve and submit to the regulator to confirm that we are still compliant with the terms and conditions of our licence to operate as a foundation trust.
Thank you very much indeed, Anne. I don't see any questions or comments, in which case can we move on to the report from the Council of Governors? And I don't intend to go through it item by item, it's quite recent. I have to say, I am incredibly impressed by the governing body. They are so committed. We always get really good attendance at every Council of Governors, and I know that they do at the informal meetings in between. I think we've got an incredibly hard-working group of governors there, and their input is always valuable. If there are any issues on that list that has been put on the agenda here of the issues that were raised, then I'm happy to take any questions. I see none, so can we note the summary, please, and approve the membership strategy, which we need to actually approval for that.
Yep.
Are there any issues around approving that membership strategy? I'll take that as agreed then, thank you. If we can then move on to any other business. Nobody's brought me at the moment any items of any other business. Chris.
Just going back to the self-certification, I did notice that we needed formally to approve it, and I wasn't aware that we actually had.
You are perfectly right, Chris. Thank you for pointing that out. Are you happy to formally approve? I shall take silence as assent. Thank you. Thank you very much indeed. In which case, thank you all very much for your attendance. I don't know if the drizzle has stopped where you are, but the sun's come out where I am, which is quite amazing. So please enjoy the rest of your day, those of you who don't have any meetings. And for those of you who are rejoining a meeting later, I will see you all at 1:45?
12:45.
12:45. I knew that couldn't be right. 12:45. Thank you all very much. And thank you all those who've attended, including the governors. Thank you.